So most of this morning has been focused on metastatic disease treatment, and we saw some updates as Neil Siegel was sharing. It was really great to see in microsatellite stable colon cancer some really new targets and some new ways of using the immune system beyond single-agent checkpoint blockade that have been effective. But what we're going to do for the second debate is look at surgically resectable disease, and not only just stage 3 disease in melanoma, that's lymph node involvement, but also in other contexts. And we have two great speakers that are going to address issues related to treating micrometastatic disease, or disease that's not available on CT scans. And we're going to have Charlotte Ariyan give our first perspective that after surgery, that's the best time to use immunotherapy. And then that will be followed by Jamie Chaft, who's done some work in neoadjuvant clinical trials in lung cancer to try to get the idea forward about, well, maybe we shouldn't do surgery and then give immune therapy. We should give immune therapy first and consider surgery subsequent. So Charlotte will give us the first perspective on it's better after surgery.
All right, thank you very much. And the only disclosure I have is that I'm a surgeon. So, of course, I was handed this part of the question, which I think is an interesting, very interesting and hotly debated question. So you're going to hear from myself and from Dr. Chaft, and we're going to talk about neoadjuvant versus adjuvant in this debate. I'm sure that she's going to tell you all the advantages of neoadjuvant therapy is that you can get it, administered with a measurable tumor, and you have this great opportunity to assess a tumor response in vivo and look at this, what they call major pathologic response, and maybe that'll correlate to survival. But I'm going to show you that there's a problem with that. There's side effects, and you could potentially, most importantly, miss your window for curative surgery. Adjuvant therapy is given after we do a complete resection. So we're administering it without any measurable tumor, and that makes people uncomfortable. We don't have a really opportunity to assess the tumor response in vivo, but we have to wait for other criteria, such as overall survival or relapse-free survival, which I would argue may actually be the better endpoints. And so in this section, all patients are going to have surgery. They're going to have a surgical chance for a cure. And you're really using immunotherapy from micrometastatic disease, which I'll argue may be the better way to go. Okay, so we do know that in early disease, in most cancers, surgery remains the most effective treatment for early cancer and gives the best chance for a cure. Our response rate's 100%. And we know that some patients will relapse, but they can give patients a good amount of time without any surgery, without any recurrence. And the problem with the neoadjuvant trial is that some patients do not go on to surgery. And so they're missing this, established treatment. So this is a trial looking at neoadjuvant checkpoint blockade in melanoma. These took patients who had stage 3 melanoma or oligometastatic, so resectable stage 4 disease. Patients received either PD-1 blockade or PD-1 with CTLA-4 blockade, and then went on to have surgery. So it was really looking at these two different treatments at the time of surgery, and then they went on to get an adjuvant PD-1. And in this trial, with the nivolumab or the PD-1 therapy, there were patients who failed to be able to go on to surgery. So you can see these patients who progressed and were no longer surgically resectable, and one patient who progressed a significant amount. And this has brought up this other idea, which I'm not going to get too much into due to time, is that some people have hypothesized that some people will have hyperprogression with treatment with immune therapy. So, and while that risk can be anywhere on the spectrum, if you're giving this therapy in patients with potentially resectable disease and you're closing that window for them, are we really hurting them? So these patients didn't go on to surgery. You can see the response rate, and I'll talk a little bit more about that afterwards. Furthermore, if you look at the neoadjuvant studies in lung, you'll see some similar trends. This is first trials, the best trial, which was done here, and I'm sure Dr. Chaft will talk about it. These patients got 2 doses of PD-1 and then went on to have surgery. And actually here, the patients, all but one patient went on to have surgery. So it was a very good endpoint into surgical resection. But I would make the argument that these early trials, which only had 21 patients, and as you look down to these other trials which have higher numbers of patients. And most recently, this trial, which was presented at ASCO, it had 101 patients and was mostly more advanced patients, stage 3A to stage B. Only 89% of their patients actually went on to have surgical resection. So again, drawing to question of whether we're really keeping that surgical window open. In addition, neoadjuvant therapy can cause toxicity. We've heard about this today, and also maybe can complicate surgery. So patients who have toxicity are going to go on steroids. They're going to try to calm the immune system down. That may increase the morbidity of surgery. We saw this in the neoadjuvant trial, again, out of MD Anderson in their combination treatment, which is the more toxic regimen, where 8 of 11 patients had a grade 3 or greater adverse event. So this is something that's going to require treatment, steroids, hospitalization, or other. Furthermore, if you look at the patients who were resected out of the trial that was done here and at Johns Hopkins, this is the neoadjuvant trial in lung cancer. You can see that although 95% of the patients actually went on to have surgery, half of the patients had their surgery changed by surgical intent. And by that I mean, out of the patients who went for a minimally invasive approach, half of those were converted to open because there was significant fibrosis and inflammation requiring them to open for the patient. So that changes a little bit the morbidity of the procedure. In addition, we don't know that the response rates of neoadjuvant therapy are different than what we would see in stage 4 disease. So, and we do have data that in the adjuvant setting, immunotherapy can actually improve survival, that it actually does work in micrometastatic disease. So this is important because you're going to hear about how people think it's important to have the tumor there to educate the immune system about the tumor. But I'm going to show you that we actually have data that prospective randomized data that shows that it actually works when the tumor's not there. Okay, so going back to neoadjuvant response rates, what you can see, I mean, historically, neoadjuvant versus adjuvant chemotherapy, for example, in lung cancer showed equal response rates. And here, if you look at the response rates in these lung cancer trials, you can see the response rates with PD-1 or PD-L1 alone or within combo is in line with what has been reported in the stage 4 patients. And if we look, for example, at monotherapy in melanoma, a response rate here, this is in the neoadjuvant setting with PD-L1 or single agent, a response rate around 25% by RECIST or pathology is also in line. It might be a little bit of a higher path CR, but about a 25% response rate overall is not out of line of what we would see. Now, combination therapy may be a little bit higher, but again, we're waiting for more numbers with that. What I want to show you now is that there is some data that immunotherapy will work better in a state of less tumor burden. And the hypothesis that comes from the fact that if you have widely metastatic disease and or if you have a large tumor burden, that maybe your immune system isn't as healthy and it's being suppressed by some of those factors in the tumor. And so some of the data comes from biomarkers of tumor burden, which have been validated in patients, such as LDH. We use that often in melanoma, and has been historically part of the staging system, and NLR, which is something called the neutrophil to lymphocyte ratio. Both of these are surrogates of the immune system and probably also of tumor burden. And so you can see here, we did a study here looking at NLR. Again, this is NLR at the time of your first treatment for melanoma, which is with PD-1 blockade. And you can see that if you have a higher or a worse NLR, you have a worse survival. Again, a surrogate for your immune system and maybe tumor burden, saying that the immune therapy will not work as well. In lung cancer, similar studies have been done, again, looking at overall survival here on the left and progression-free survival on the right, and showing that there's a worse response if you have a worse NLR and LDH, again, associating this a little bit with tumor burden. But if we look in the true adjuvant setting, we actually have prospective randomized data that immune therapy works and improves survival. So in the melanoma world, this was our first study which showed this. These took patients with stage 3 melanoma that were completely resected and randomized them to either get CTLA-4 blockade, which at the time was IPI, or placebo. And what we saw was that there was an improvement in recurrence-free survival. You can see here on the left in the curves, the IPIs up top. And this improvement in recurrence-free survival did translate into an improvement in overall survival, shown here. This is now being tested and has been tested in patients who've had complete surgical resection, so again, in the micrometastatic setting, and we see an even better response and lower toxicity with PD-1 blockade. And this is recurrence-free survival, and early signals are that this also translates into an improvement in overall survival. So this is prospective randomized trial through many different institutions demonstrating that immune therapy works in micrometastatic disease. Lastly, one of the arguments for neoadjuvant therapy is that you're going to get an enhanced immune activation because the tumor is there and the immune system can be educated against the tumor with the neoadjuvant approach that you won't see with the adjuvant approach. And I'm going to argue that we've failed to demonstrate this. So if you look at the paper here in lung cancer, this is again where they gave 2 doses of PD-1 prior to surgery. One of the things that they did very eloquently was to look at the neoantigens or their predictives. So these are basically the proteins that they predict would bind to MHC class 1, and then they tested them and looked for the presence of these clones and did functional tests with blood in the patients. And so what you can see here is that these were the 3 kind of top clones here, amino acids predicted sequences. And you can see here in the peripheral blood, this is before the first dose of Nevo, some of these were pre-existing. All these went up with treatment, but some were there beforehand. And you can see that while they were in the tumor, they were also in other places as well. So we don't know, for example, that this clone is better than this one or that these are better than that one. So it may be that having the tumor there was important, or maybe it's not important at all. And like I said, some of these were pre-existing and in the periphery, in the blood. Lastly, and I would make the argument that that just shows you that happens. And so that probably happens in a variety of different circumstances. And so the only study that's really looked at whether this happens better in a neoadjuvant setting as opposed to an adjuvant study was a great study done by Christian Blanc and Tom Schumacher out of Europe. And they were looking at patients who received either neoadjuvant therapy or got surgery and had adjuvant. And their primary endpoint was looking at path response, but their second one was looking at tumor-specific expansion of T cells, doing the same prediction models of binding to MHC and seeing which clones they thought were important. And so their pathologic response rate definitely was encouraging with the neoadjuvant approach, and the data's not far enough out to see if neoadjuvant's going to have a better survival or not. They looked at clonality of the tumors. So basically, the patients in the adjuvant setting had less new clones detected than patients who had neoadjuvant therapy. So you can see here, the darker line is clones detected at baseline, and there was an expansion in the neoadjuvant. And then these are newly detected clones in the light blue. So there's a little bit more of both in the neoadjuvant setting, and in the adjuvant setting, you can see that there is a less amount, but again, we don't know the functionality of these two. But more importantly, so this is just clonality in general. When they tried to look for tumor-specific T cells, they could only detect a single neoantigen-specific T cell response in 2 patients, and they actually abandoned this portion of this arm of the trial after saying that they were not going to be able to say that there was a difference between adjuvant and neoadjuvant. So I think overall we failed to demonstrate that we're increasing tumor-specific cells by using neoadjuvant over adjuvant therapy. It probably happens in people who have an underlying immune event already that you're releasing the brake on in both settings. Okay, so I hope I've told you and proven to you that adjuvant therapy is superior, and for the variety of reasons which I said. It ensures that you're going to get all your patients to surgery. You're not going to miss the window for potentially curative surgery with less toxicity, potentially, and maybe a better minimally invasive approach in some areas where that matters. I've also tried to show you that the therapy administered when you're in the presence of a lower tumor burden is possibly more effective. And to date, we don't have any data that demonstrates that you're getting enhanced anti-tumor activity with neoadjuvant over adjuvant. So thank you very much. And you'll hear from me.
Okay, great. Thank you, Charlotte. And we'll call up Jamie Chaft to give us the counterpunch to this, which is that we should be treating patients prior to surgery. And following Jamie's presentation, we'll have just a brief panel discussion where the kind of mid-morning presenters will come, answer some questions, and I promise we'll be right on time for lunch at 12:30. Thank you.
That was a fantastic presentation, and I have little to argue with in all the data that was presented, but I'll try to give a slightly different stance. I'm going to incorporate a little chemoimmunotherapy since we are not all lucky enough to treat diseases that are so exceptionally sensitive to monotherapy like melanoma. These are my disclosures, the main one being I treat, study, and live lung cancer, so there might be a little bit of a bias to lung cancer data here. So why neoadjuvant? I'd start with opportunity. I'll give you a little data on efficacy, tolerability, fully acknowledging some of what was already stated, and then the reality of clinical investigation, and that's probably the real reason we should be studying neoadjuvant immunotherapy. So what's the opportunity? Surrogacy. And I know there are a lot of holdouts for overall survival, and perhaps we all should be. But the reality with many of our resectable solid tumors is that too many patients are dying of relapse. Per the FDA, a valid surrogate endpoint may be used in place of a clinical endpoint, and that surrogate endpoint must be reflective of the study intervention and reasonably likely to predict clinical benefit. Our colleagues in breast cancer have taken this statement by the reins and run with it, and the rest of us are trying to catch up. What about efficacy, the true biology? So this is a preclinical model, a mouse model with a breast cancer orthotopic injection. And you'll see here, if you can, the injection in the adjuvant versus the neoadjuvant space. See if you can see the mouse here. I know this is small and the reference is widely circulated, but these are the little critters who receive neoadjuvant PD-1 as opposed to adjuvant, where there was no survival advantage seen. This was pretty intriguing. But what do we know in the clinic? And we really have a very small study just to go on, with the exception of a few that are combination studies. This is the PURA-1 study, a study of neoadjuvant pembrolizumab in muscle-invasive urothelial bladder cancer. Patients with clinical T3 or less. They included 4. Eligible for a radical cystectomy. They received 3 doses of neoadjuvant pembrolizumab. The primary endpoint was pathologic remission, so PT0 tumor. And pretty remarkable, they did see an enrichment by PD-L1 score, but in all comers, they had a 40% pathologic regression rate. And based on the data, this is far superior to the standard of care cisplatin-based therapy in a non-comparative setting, admittingly. And a standard of care therapy that most patients with this disease state can't receive, similar to the lung cancer patients who often are not cisplatin eligible. So very intriguing and certainly, enough fuel for a randomized study. This is another figure from the study you've already seen presented, some of our correlate data that was well summarized. But this is a study of neoadjuvant nivolumab in resectable non-small cell lung cancer, just 2 doses. I think what was stated is that the major pathologic response rate is comparable to what we see in advanced disease, and that was inaccurate. In advanced disease in unselected patients, we see a clinical response rate of about 10 to 20%. And in this very small pilot study, we probably got lucky. We saw a major pathologic response rate, something that's arbitrarily defined as less than 10% viable tumor cells, because historically in lung cancer, we've never seen complete pathologic responses. And we saw this endpoint in 45% of patients. One of our patients was not resected, and she was not resectable upon enrollment. But this was really intriguing, and this small 20-patient study has really fueled industry to sponsor 4 randomized controlled phase 3 studies. Can we do better? And this is some chemoimmunotherapy data. So in lung cancer, we have really seen the field move towards combination chemoimmunotherapy in patients whose tumors don't highly express PD-L1. This is a study of carboplatin and paclitaxel with nivolumab preoperatively in the highest risk resectable patient population, and that's stage 3. These are patients that by definition do not have upfront surgery. They almost always have preoperative therapy with chemo or definitive chemoradiotherapy. And in almost every study of induction chemotherapy, almost a third to a quarter of patients do not go to surgery. They are unresectable. So the data we've seen presented earlier from monotherapy and combination studies was intriguing, and this is even more so. In this Spanish study, I have represented their data in intention to treat, which is, I think, more realistic, including patients who did not go to surgery. The complete pathologic regression rate was 52%. So that is absolutely unheard of. I'll highlight that here. Just to put it in perspective, the CR rate to cisplatin-based chemotherapy in most published series is 4%. So this is something we've never seen before and are really excited about. Of course, our breast cancer colleagues have beaten us to the punch with their exceptionally fast enrolling studies. This is an amazing study of chemotherapy with or without pembrolizumab, a randomized placebo-controlled study, which did have an adjuvant phase as well, in triple-negative breast cancer, where you can see that the combination of chemotherapy with pembrolizumab had a significantly higher pathologic response rate than chemotherapy alone, as well as a beautiful splitting of the curves at their very first interim analysis. This is likely to translate into survival advantage, and that's something we're going to have to wait and see, but very intriguing data in a study that enrolled amazingly well. We saw this data a little earlier. Really, the only study we have comparing neoadjuvant to adjuvant immunotherapy. In almost all of the ongoing lung cancer studies, as well as the breast cancer study I just presented, the intervention arm has both a neoadjuvant and an adjuvant arm, so we won't clearly answer that question in any of those studies. And this study, while intriguing, is just too small to tell. So let's think about the other important elements of preoperative investigation: tolerability. We know in lung cancer that chemotherapy is far better tolerated preoperatively, and that in most randomized studies, there is no signal of harm in terms of proceeding to surgery. But we have to remember, as Dr. Ariyan pointed out, surgery is the curative modality here, and we should not interfere with that ability to get there. For the immunotherapy population, patient selection is key, actually taking a good personal and family history, acknowledging and respecting relative contraindications to immunotherapy, particularly if there's an alternative treatment plan. Low-grade toxicity should be observed and not overtreated, and endocrinopathies evaluated for preoperatively. These are all things we learned in our early experience giving nivolumab preoperatively. To date, all feasibility and safety studies have not shown a harm signal, with the exception of the combination CTLA-4 PD-1 studies. So now I'll get to the reality, and this is the take-home for me as a clinical investigator about why we should be doing preoperative studies, and it comes back to that opportunity of surrogate endpoints. This is EA 5142. It's an adjuvant study. Why is the neoadjuvant argument talking about an adjuvant study? I'll try to show you. They take a long time. This is a study that I served as the national study chair for and completed accrual just about 2 weeks ago now. It's a randomized study of a year of adjuvant nivolumab after completion of standard of care therapy for resected lung cancers of clinical stage to merit adjuvant therapy. So in years 7 to 10, we will learn a bunch of stuff. Will the study close early for futility? Will Nevo improve disease-free survival in everyone? Will it improve disease-free survival in PD-L1 high patients? Or will it improve overall survival? That answer is probably a decade out from study launch. Let's put it in human perspective. I was pregnant when I proposed this study to the cooperative groups, and as those of you know who have worked with the NCI, it took 2 years for the study to launch. It completed accrual on my son's first day of kindergarten. So when we know if this study will be positive, we will know which of these children my son has turned into, I got a curveball actually on the day of the study closure. This was the avatar he chose for his math application, so I might have to update my pictures. Now the breast cancer investigators have really put us in our place. This is their Keynote 522 example. So assuming an industry study is activated much more quickly than an NCI-sponsored study, their huge randomized preoperative study completed accrual in 18 months, and its definitive interim analysis was presented 1 year later. So I'll say that icon there is you running to bribe someone to get your kid into preschool versus my kid's already in kindergarten and we just completed accrual. So there's a huge difference in the reality of conducting neoadjuvant versus adjuvant investigation, and these years are potentially years of patients' lives we can be saving. So to summarize my advantages, I think it's earlier treatment of micrometastatic disease, and that's important. Some of those patients who don't get to surgery shouldn't have gone to surgery because they would med out by the time they come back for their first clinical visit. Time for preoperative pulmonary optimization. This is really important in the thoracic oncology clinics, and I'm sure many others. Better tolerability and compliance, at least this is the data we have in lung cancer. We can evaluate the tumor in vivo for efficacy. It's rewarding from an oncologist's perspective to see something shrink versus toxicity with nothing to watch. And possibly to study adaptive interventions if we are not succeeding with our first systemic therapy. And finally, at least in mice, we have the immunologic advantage of the tumor, but I agree with Dr. Ariyan, we have yet to demonstrate an immunologic advantage in human beings of the preoperative setting. So I'll summarize with it's really time for opportunity. Nearly every academic institution has many studies, both preoperative and postoperative, and we should be offering our patients who are appropriate these interventions on a clinical study. The goal should be a study for all, and we should be in curing lung cancers and other cancers as well. And I'd say as technology is improving, our biomarkers are getting better, particularly circulating biomarkers. We're getting to an era of personalized curative cancer therapy, and we'll see our studies evolve in the next few years, and I hope there'll be neoadjuvant studies. Thank you.
Okay, great. Thank you, Jamie.